Hello, good evening, everyone. Thank you so much for joining our inaugural event of ACAMH India. I am Soumitra Datta, consultant child psychiatrist working in Tata Medical Center, Kolkata, and I also have a visiting affiliation with the University College London. We would, be delighted that ACAMH will be coming to India for some time now. We have been thinking about that, and we are hoping that we would have a active group of members of child mental health professionals, teachers, everybody who are interested in children's mental health. I would first like to invite Dr. Gordana Milavich, who is the chair of ACAMH UK. Gordana is a consultant child psychiatrist and currently the chair of Association of Child and Adolescent Mental Health. I knew her in the capacity of my clinical director when I was a consultant child psychiatrist at the Maudsley Hospital, where Gordana, led the team of child psychiatrists. There were more than 40 consultant child psychiatrists in the institution. And Gordana, since then, has held various posts. She was the co-chair of the Child and Adolescent section of the World Psychiatric Association. I've always found Gordana to be very friendly, approachable, and a very able clinician. Her particular interest is mood disorders in children, and she headed the National Specialist Affective Disorder Services of the Maudsley Hospital. So please, Gordana, welcome the audience today who have joined. Thank you. Over to you.
Thank you, Soumitra, for this wonderful introduction. As chair of ACAMH, I would like to say how privileged and honored I am to be invited to say a few words at the outset of the inaugural meeting of ACAMH India. Every year, the World Health Organization celebrates World Mental Health Day on the 10th of October each year. This year, the World Mental Health Day has been entitled Mental Health in an Unequal World. And I would like to take just a few minutes of your time to say something about ACAMH and World Mental Health Day. It is estimated that 10 to 20% of children and young people worldwide have mental health problems. 9 out of 10 of those children live in low and middle income countries, whereby they constitute almost half of the entire population. Mental health difficulties, as we all know, are one of the leading causes of disability in this age group. I can say with confidence that the mental health needs of children and young people are not adequately met anywhere in the world, and particularly not in low and middle income countries. And let me just remind you that in addition to the immediate effect that mental health disorders have upon children and young people, research has shown that 75% of adult common mental health disorders begin during childhood, with nearly half developing by the age of 14. And we have, this is old research which was done back in 2005, and we now have updated meta-analyses showing and demonstrating the same epidemiological facts. We come to COVID and the pandemic, which has brought into sharp focus the social, economic, health, and cultural inequalities between individuals in our communities. And with the onset of the pandemic, children and young people around the world were forced to experience varying degrees of social deprivation and isolation. Again, we have research which has demonstrated that the impact that COVID-19 has had upon the childhood population has been considerable, and that the number of probable disorders is rising. I come now to our association, the Association for Child and Adolescent Mental Health. We have over 60 years of practice of disseminating evidence-based scientific research and on child and mental health. And we do this through our publications and our events, our journals, are truly international with a global outreach. The association's international activities have strengthened the establishment of more branches, and we now have more countries, like in India, where we are including regions where there are scarce resources and few mental health professionals. And I can't tell you how much I welcome what is happening now in India. And India ACAM has become the shining example about how these international links can be strengthened. So let me just say that young people with mental health conditions everywhere remain the subject of little understanding, stigma, and lack of effective treatment. We have many challenges to face. We have excellent, as you know, evidence-based interventions which can be delivered at low cost. But we must ensure that this information is available to practitioners, researchers, and policymakers, both in health, social care, schools. And this is ACAM's main goal. And to help meet some of these challenges, we have free memberships. We are going to digitalize some of our materials. We're going to make them even more available. And I think India ACAM will take a huge role in facilitating this. So my final words are that by focusing on mental health in an unequal world and by sharing best evidence and improving practice, we hope that our educational resources based on scientific knowledge, evidence-based practice, and ACAM's global reach will continue to contribute to attaining the highest standards of health, mental health and well-being in children and young people, their families, and their communities. Thank you very much, Soumitra, for inviting me again. And I wish all of you in a very wonderful conference. And I want to thank our colleagues in India who have put today together and have worked really hard for what looks like a wonderful program. And of course, I want to thank our CEO, Martin Pratt, and the office, very much so, who have enabled this development to take place. And finally, I want to thank the audience who are here today and all of those who will be watching us in the future, and to thank you for your participation and to say, enjoy the lectures today, and please keep in touch. Thank you.
Thank you, Gordana. That's wonderful that all of us feel so energetic, and thanks to ACAM again. I would now introduce our first speaker, who does not need any introduction, either nationally or internationally. Our first speaker, I'm so pleased ACAM India would be, the first speaker would be Professor Sekhar Seshadri. Shekhar graduated from Maulana Azad Medical College in Delhi and did postgraduate training from National Institute of Mental Health and Neurosciences, where he has been since then. He is a senior professor in the Department of Child and Adolescent Psychiatry, and he, with his colleagues, had actually started the specialty of child psychiatry in the country. And many of the first students whom Dr. Shekhar had would be today with us, and his colleagues. Dr. Shekhar, besides working with children and adolescents in the capacity of mental health professionals, he is actively involved in areas of gender and sexuality, violence, trauma and abuse, and children in difficult circumstances, because many of the Western paradigms may not be always possible to be applied in a country like India. However, we do need local solutions for complex problems. Shekhar is an avid researcher and very interested in qualitative research, in life skills screening, education, and community and school mental health programs. Thank you, Shekhar. Over to you.
Thank you very much, Soumitra. What a singular honor for ACAM India and this presentation today. I would like to start by echoing some of the thoughts expressed by Gordana, particularly as I wish to embed the whole phenomenology of depression in the context of the current pandemic. I want to draw your attention, friends, to the fact that pandemics of the nature of COVID have a disproportionate impact on the more vulnerable populations. And if you look at the whole narrative since the pandemic hit us last year and the several cycles of lockdown with daily wage workers and migrant workers and their young and adolescent children, and the frustrations that played out in adolescents and young people's lives, and the nature of services that are available in LMIC countries, it was, I think, timely that child protection risks, as they play out during historic periods in humanity of the nature of COVID and its relationship with mental health, need to be taken into consideration. And it's in this context that we started in NIMHANS a national initiative and an integrated resource on child protection, mental health and psychosocial support called Samvad. And I've taken the liberty, friends, to put on the chat our site so that you could have a look at this and have an idea of the kind of stuff that we're presenting. Having said that, I would like to go to the whole context of what I want to share with you today, which is the phenomenology of adolescent depression. The reason I mentioned COVID was, if you look at the second wave in India and the kind of storm that swept us all with younger people, even those who were vaccinated, being taken away, and many children and adolescents losing one or both parents, the whole experiential context of loss and grief and how depression plays out in that location becomes an important cultural issue and a topical and an immediate issue to really re-examine the phenomenology of depression in young people through the lens of social circumstances. Having said this, why is it important really to understand and pay attention to the phenomenology of adolescent depression? And the data is fairly clear. The lifetime prevalence through adolescence is considered to be as high as 20%. The issue is not so much about this high prevalence. The issue is also that it is associated with poor academic performance and impaired social functioning, but some very problematic behavioral consequences and concomitants. One, of course, being self-harm behaviors, and the other, the propensity for substance use. There has, of course, over the years been this debate on recurrence. And the truth is, or the unfortunate truth, shall I say, is that a major proportion of depression in children in adolescence is actually underdiagnosed and undertreated. This is a curious phrase that I decided to coin for the purpose of my presentation today, and I called it the old history. And I recall during our postgraduate studies in the late 70s and the early 80s, particularly with Pekel's work, where in the classification of depression, he alluded to young people with depression who had personality disorder. Somewhere around that time, the whole issue of whether the phenomenology of depression in adolescence was different to that in adults. Did it have atypical features? Notwithstanding the fact that later, atypical depression itself, both in children and adolescents and in adults, has come to be a major focus of examination and concern for very many mental health professionals. Then there was, of course, the whole depression of unipolar origin, recurrent depression, as some people refer to it, and depression of bipolar origin. And the whole interesting notion of double depression. So people who had, let's say, mood disorder and dysthymia together, or who had mood disorder and perhaps different forms of affectation in the mood or the affective realm. And these could be adjustment disorders or stress reactions or PTSD in prone individuals, and how do these play out as far as the phenomenology is concerned. Now, if you look at this old history against the fact that depressed patients with atypical features are more likely than non-atypical depressed patients to exhibit the following characteristics, it becomes very clear that one of the phenomenological characteristics, other than the core features of sadness and anhedonia, the typical symptoms that are mentioned in either DSM-5 or ICD-10, is that atypical features are seen in a younger adolescent population. They are associated with greater comorbidity. There is the coexistence of what seems to be affectations in the personality realm, perhaps consolidating post age 18 into diagnosable personality disorders. And of course, sometimes it's characterized by irritability and anxiety and more lifetime non-serious suicide attempts. But other than some of these critical features, the fact that there is a longer episode duration, a younger age of onset, and higher rates of bipolarity, and coexistence of different forms of anxiety or eating disorders, of substance use disorders, of reverse rhythms, and absence of certain core features of melancholia, as was seen in older literature, particularly with adult depression or later onset depression. If we keep these features in mind and really look at the diagnostics and clinical features as per the prevailing nosological systems, whether it's DSM-3 or the 11th revision of ICD, depression must be diagnosed in children and adolescents using the same criteria. However, DSM-5 suggests that the criteria of the presence of depressed mood can be replaced by irritability in children and adolescents. And this is probably the reason why depression in adolescents is unrecognized and underdiagnosed. Because this irritability is seen as part of normative adolescent development, and often the presence of its pervasiveness is not recognized as a manifestation of mood disorder. Additionally, the diagnosis of persistent depressive disorder, which is the equivalent of dysthymia, requires a duration of 1 year in contrast to the 2-year duration required for adults. So this is very critical because if you look at depression, which occurs not in the context of mood disorders or affective disorders, but dysthymia, adjustment disorders, various forms of dysphoria, distress, depression that occur for periods of about a year, either in context of life's predicaments or stress, relationship issues, performance issues, and so on. There is always the danger of irritability being misdiagnosed or misinterpreted as an understandable response to a developmental stage, and therefore these kids continue to suffer, continue to have the kind of dysfunctionality that I have alluded to in the beginning of my presentation. If you cast a glance then at an expanded framework for phenomenology, And let's forget about the possibility of organic causes. The phenomenology of adolescent depression almost mandates that we look for anxiety, we look for substance use, we look for stable personality dimensions, we look for features of externalizing disorders, both conduct, oppositional defiant, and attention deficit hyperactivity. But we also look at dissociative and conversion symptoms. Now, this is of particular interest because of recent times. I have been working quite extensively with an international society for the study of trauma and dissociation. And this is a body of very serious practitioners who look at the relationship between trauma and dissociation and its triangulation with states of depression, sadness, dysphoria, mood issues as a particularly critical clinical complexity to contend with. Whether this is one-off individual trauma or an individual experiencing and enduring chronic trauma. The trauma could be of abuse, it could be loss and death and grief, it could be due to personal illness, or it could be in the context of collective trauma, as indeed the current pandemic is likely to be for vulnerable populations. But if you look at natural disasters or man-made disasters of nations and countries which undergo collective trauma, what is the impact of that on the more vulnerable populations, particularly adolescents? But increasingly it is being found that suicidality has become a very complex and a very important issue to keep in mind as far as the phenomenology of adolescent depression is concerned. Additionally, it is suggested that if one has to understand phenomenology, one also has to understand dynamics within the family, whether it's discord or psychopathology. Phenomenology does not refer only to core symptoms of depression, but it also refers to the functioning dimension in terms of school performance and behaviors like school refusal and social withdrawal. Then there are, of course, the specifiers for severity and subtypes of depression, such as symptom severity or symptom dimensions, whether it's anxiety or psychotic or catatonic, melancholic, reverse vegetative symptoms, and the presence of comorbidity in functioning then. So that's a kind of framework and a range of how phenomenology really needs to be addressed. And if we therefore cast a glance at the whole issue of comorbidity, and you look at both old literature, and by old, I'm talking about literature that's about almost 30 years old, where the findings were that nearly half the subjects had coexisting separation anxiety disorder, I beg your pardon, and regardless of age group or gender, and subjects with combined depression and anxiety were more severely depressed than subjects with depression alone. And a sizable minority, especially pre-adolescent male subjects, also had conduct disorder associated with depression. Now, this is almost 30 years ago. But if you look at what happened following on, it appears that most researchers and clinicians now agree that children and adolescents are able to develop depressive disorders. And there also appears to be a consensus that developmental level has relatively little influence on the phenomenology of depression. Please mark this. Developmental level has relatively little influence on the phenomenology of depression. If you look at more recent stuff, 20 years later, but still about a decade and a half years ago, that depressions that fail to meet the diagnostic criteria for major depression, as I've said, they are underdiagnosed and undertreated. And although they are clearly milder, it is associated with marked suicidal thoughts, plans, and attempts, recurrence, and a high degree of comorbidity. And look at these figures, friends. 40% of depressive adolescents who had attempted suicide had no contact with mental health services. This is exceedingly concerning and disturbing statistics. Building on this, therefore, if you look at the phenomenology of adolescent and adult mania in hospitalized patients with bipolar disorder, the whole unipolar bipolar, compared to adults, adolescent patients have higher risks of mixed bipolar and lower rates of psychotic features, and higher ratings for many depressive symptoms, again, suicidality. If you look at the phenomenology and psychosocial correlates, the patterns are very similar in major depression and dysthymia, but significant differences occur in comorbid conditions, more anxiety disorders, alcohol, and again, suicidal behaviors. A review of comorbid depression in pediatric adolescent ADHD states that youth with attention deficit hyperactivity disorder and depression together have more severe course of psychopathology and a higher risk of long-term impairment and, again, suicide. Every which way that you look at this literature and the phenomenology of adolescent depression, other than many of the atypical features, reverse vegetative, there is one common factor that seems to be recurring. And this brings me to the whole issue that while there may be frequently mentioned symptoms like depressed mood and apathy and boredom, loss of pleasure, loss of interest, and suicidal ideation, with girls and boys being at similar risk for recurrent depression. But as girls get older with high rates of eating disorder and low rates of externalizing compared to boys, the phenomenology of what is now known as non-suicidal self-injury among adolescents, with reasons for engaging in this behavior, including regulation of emotions and to elicit attention. And the correlates of this behavior includes history of abuse, depression, anxiety, alexithymia, hostility, substance use, dissociation, and suicidal ideations and behavior. This, my friends, is the definition of non-suicidal self-injury. And if you look at criteria C and criteria E of NSSIs, which is, of course, described in the last 1 year, the individual has on 5 or more days engaged in intentional self-inflicted damage to the surface of his or her body of a sort likely to induce bleeding, bruising, and so on, with no suicidal intent. Look at what criteria C states. Interpersonal difficulties or negative feelings or thoughts such as depression, anxiety, tension, anger, distress. And E, the behavior or its consequences causes clinically significant distress or interference in interpersonal, academic, and other important areas of functioning. Therefore, depressive disorders, particularly with co-occurring disruptive behavior or anxiety, confers an increased risk to all forms of suicidal behaviors, including thoughts, plans, and attempts. The association between suicidality and externalizing disorders is also well documented, and combined with depression increases the risk of suicidal behavior. Conduct disorders co-occurring with mood, anxiety, substance use are found in girls with history of suicidal behavior in almost a third of adolescent male suicides. And interestingly, conduct disorder also appears to confer an independent effect on suicidal behavior controlling for depression. Now, this was work that our friend Maria Kovacs from Pittsburgh has been saying for the last 30 years that the relationship between depression, conduct disorder, and suicidality, that the risk of suicidality is much more in the combination of depression and conduct disorder than in depression or conduct disorder alone. And this is the importance, therefore, of understanding complex phenomenology in adolescent depression, which is why it is stated, always evaluate for comorbidity and the existing phenomenology for anxiety, for substance use, for personality dimensions, for externalizing disorders, and for dissociative conversion symptoms. Consider the possibility of bipolar disorder, especially with those who have psychotic symptoms and reverse neurovegetative functions and irritability with a family history of bipolar disorder. An assessment of suicidal behavior is absolutely imperative, in addition to assessing levels of dysfunctionality and evaluation of the support systems that a child has. But I would like to end with a very interesting thought. Two, rather. One, of course, is that COVID is a current pandemic. Adverse childhood experiences have been an everlasting epidemic. And the relationship between developmental exposure to adversity and affective disorders and depression, and adversity includes physical, sexual abuse, neglect, and loss experiences. These are stresses that can occur at any point of time during development. And the unique temporal relationship to specific depressive symptoms, if you take that as the focus, what happens to stress exposure is, of course, it varies by gender and the duration of abuse, but the phenomenology of depression in this context can be broken down into categories: mood and affect, anhedonia, energy, working memory, sleep-wake cycle, appetite change, suicidality, and general malaise. One can conclude, therefore, from ACEs that sensitive periods for affective-related behaviors, anxiety, mood, and so on, occur early in life, whereas other aspects of depression are associated with adversity later during adolescence. And the trajectories of individual depressive symptoms in adolescence, with gender and family relationships as predictors. And what happens here is that these syndromes increase substantially during adolescence with within-person changes. All depressive symptoms increase over time except psychomotor. What also happens here is that there is significant gender difference, with more rapid increase in worthlessness, and guilt in girls than boys, and concentration decision-making in boys. And a lot of them are actually related to family dynamics, which is another nature of assessment phenomenology that one needs to keep in mind. I would like to end with a provocative slide, and I call this, friends, as the poverty of epistemology. All the stuff on depression and phenomenology, comes from very core standard experimental research. And I have often asked the question, does knowledge come from only double-blind studies? Existing literature suggests that a correlation between the thematic core of an adolescent's personal account of depression and the trajectory of her personality development. This has not been explored. And therefore, the qualitative experience, the subjective experience of adolescent depression is a very important aspect of phenomenology. And this thematic core are called mental structures. And there are varieties of depressive experiences. There is, of course, a presumed dependency on the trajectory of personality development, a distinction between interpersonally directed depressive experiences like dependency, loneliness, abandonment, and self-critical depressive experiences such as inferiority, unworthiness, failure, and feelings of guilt. This is exceedingly critical because these changes account for what depression is actually about. And Matthew Radcliffe has recently offered, it's a philosophical analysis of the dimensions in relation to which the experiential field of depressed adolescents suffer fundamental transformations. Specifically, Ratcliffe proposes conceiving of experiences of depression in terms of a morbidly altered sense of the space of possibilities. And this is what adolescents say. She labels this as misunderstandings. Well, I would say one actually feels captured in a sort of a hole that one can't come out of, and for this reason, no one takes one seriously. Not that one is being jeered at, but one has the feeling that one is simply not being perceived. I feel like running around at a lower layer. I would compare it with a kind of a messy ball of yarn, like a labyrinth, just one comes out of it again and again. Or another kid's description of what he calls the sad phase. One somehow feels bad in a particular way, not necessarily worse than one is sad. It's weird somehow, like one is not really within the world. Or someone says, I simply have the impression that time runs as though it has been bent, and that I don't know, that time somehow lags behind a little, but somehow I have to think about things constantly. And this subjectivity, the subjective world, the subjective phenomenological world of the child is indeed what we need to keep in mind when we really think about the phenomenology of adolescent depression. So friends, what I've tried to do is I've taken you through a quick historical journey, looked at atypicality, looked at the whole personality dimension, various clinical aspects of depression, its interesting and very complex and concerning link with suicidality, and the importance of the subjectivity of an adolescent's experience that further informs the kind of therapeutic work that one would do, especially when you're doing narrative work and assisting people to come out of their predicament. Thank you very much for this invitation and for your kind attention. I'm open now to any questions and answers. Thank you very much.
Thank you so much, Professor Shekhar Seshadri. We do have some time for questions. So if anybody has any questions, or anybody from the attendees or panel members, you can write it in the chat or the Q&A, and I'll translate it to, read it out for Professor.
Can I just say a few words, Dr. Datta? I would like to thank Professor Seshadri for this very comprehensive overview of what is, I think we realize more and more, a very heterogeneous disorder with a heterogeneous etiology, where it's complicated and where we have a varied complex group of possible causes of depression. And we're realizing this more and more. And I just wondered if I could ask Professor about some of the newer theories that are dominating the adult world, but more recently also the child and adolescent psychiatry literature. And that is of inflammation and autoimmune responses in the causation of depression. And this is obviously linked to early childhood abuse as well, and maltreatment, and embedding of various autoimmune and stress responses at an early age. I just wondered what your views were, Professor, on some of these new developments.
Thank you very much, Gordana, for that very interesting question. Let me address it in two quick ways. It's very coincidental that you asked this question, because I was also reading something called the SCAR theory. And the SCAR theory of adolescent depression actually is more a dynamic explanation of psychic scars. But it is true that chronic exposure to trauma does cause neurobiological changes, which have been even understood from fMRI studies. And there are structural changes that occur in the amygdala, to kids who have been exposed to adverse childhood experiences in a chronic fashion. Having understood this and its further ramification in terms of neurobiology, whether it's autoimmune or whether it is trauma induced, the clinical approaches, because sometimes the phenomenology is the same, that is, you have trauma symptoms, and more recently what we call as complex PTSD or complex post-traumatic, which is trauma symptoms along with significant and serious dissociative phenomena. And what this means in terms of actual treatment planning, and this is where good clinical evaluation on the one hand to look at those people with this chronic trauma who have gone into affective dysregulation and would actually need mood stabilizers in addition to psychotherapeutic work, and those who need intensive long-term healing interventions, which is trauma-informed care, and a more recent development on trauma-informed care, which is healing-centered engagement, which calls for very deep engagement on the part of a therapist. So this is a framework that ACAM, I think it would be an exciting area for ACAM to consider, given exactly what Gordana is saying about how heterogeneous adolescent depression and its contexts are. Suffice to say, context matters. And if you take contextual issues into consideration, I think elegant, robust, and effective methods of assistance can be provided. Thank you, Gordana, for raising this.
Thank you.
I see that many other questions have been raised. I'm conscious of the time, Soumitra, so I will try. And Ravi Kant has asked a question about a teenager with borderline personality traits with a major mood disorder with severe non-suicidal self-injuries. And this whole business of wanting to remain in depression and do not want to improve and not accepting any treatments this is a huge clinical predicament that many of us kind of face. And I think one of the most critical elements here is the establishment of a therapeutic alliance. And that occurs through the processes of context establishment along with the teenager. That is, we do not problematize the teenager, but we problematize the problem. And this is where I think some of the more established practices of dialectic behavior therapy and its further extensions work, because the approach is Socratic here. These are very arduous and complex processes, and one often has to suffer and endure the anxiety and terror of not making a headway in session 1 or session 5 or session 12. But I think that sometimes persistence and authenticity ultimately, pays, even if there were 2 out of 10 who ultimately remain in this recalcitrant state. Arif's question, what is the reason for less data on mental health in the northeast part of India, especially among tribal adolescents and ethnic groups? Arif, I think more and more epidemiological data is coming through. If you look at the National Mental Health Survey, there was some effort for it to have a pan-national. Of course, the child and adolescent part of it was not an extensive part of the National Mental Health Survey, but also the ICMR study that we had done earlier was just in a couple of centers. I think it ultimately, depends on the kind of priorities and the professional, how professionally driven, research is. And I would like to believe that one of the advantages of organizations like ACAM is actually to assist in the development of small studies in these kind of areas, to really look at what actually Gordana mentioned as, are there cultural dimensions in Elmic countries about the experience of distress? So that's one thing that we'll have to keep in mind. That Priya DAS, the depression anxiety scale, is used increasingly in many of the papers that come to me for review. I do a lot of review work for many journals, and it's been translated. It seems to be used quite a bit. And while these tools have their own place, and in fact, there's an enormous amount of literature on the use of evaluation and of tools to both diagnose as well as assess the severity of depression. But ultimately, these are tools that are used a lot in research work, not so much in clinical work. Just to give you an idea, and link this with suicidality, there's a difference between a person in a situation of distress who says, I'm in a difficult situation, as opposed to a person who says my difficult situation is intolerable, as opposed to an adolescent who says I do not wish to live, as opposed to one who says I wish to die, as opposed to one who says I do not wish to live. They're phenomenologically not the same. I wish to kill myself. They're phenomenologically not the same. And while a lot of these scales are elegant in which but they are kind of, let's say, categorical, or they catch dimensions in terms of severity, but they don't catch the phenomenological nuances of a given adolescent's predicament. I will take the last couple of things. The major barrier to treatment is the fear of medication, which is true. And I think a lot of discussion is required. See, there is a tendency to polarize into two extremes. One where mild or minor forms of affectation, where a couple of sessions of therapy would help, are unnecessarily treated with a combination of drugs. And on the other hand, children who are suffering, there is a tendency to say that children do undergo fear and anxiety, and they are developmentally appropriate, and you do not prescribe because you feel that children naturally and developmentally feel this way and allow the child to suffer. So I often tell parents that the choice is not between medication and therapy. The choice is between therapy or therapy plus medication. And I think if one has extensive discussion about the hesitancies behind medication rather than forcing the agenda, it goes a long way in allaying their anxieties. That there are, of course, some questions on whether this pediatric disorders of autoimmune, the PANDA disorders, are they misdiagnosed as depression? To the best of my knowledge, movement disorders, OCD, and so on. But this is something I'll have to really reread at some point of time. And Ramya, thank you for your perspective that the issue that you've raised on depression presentations in adolescents with ASC, and we have exactly 2 minutes left. I would not be able to respond offhand because I'm desperately trying to figure out what ASC stands for.
Professor, what we could do is that Martin was suggesting that we could do some video or question answers and post it in the ACAM after your videos is there.
That will be lovely.
Yes. So it's up to you.
Thank you very much for your patient listening, and do look at our national initiatives links. As Soumitra knows, we do not believe in copyright, we believe in copyleft. All this is material that we would love ACAM and the networks to use and disseminate widely, adapt it. It's intended for that reason. Gordana, Michael, Soumitra, thank you very much for this opportunity, and over to you.
Thank you so much, Professor. So I'll just It was a wonderful insight into the value and importance of phenomenology. There are lots of questions. If we have more questions, we would either do videos or answer them in sort of amalgamated form for all the sessions. Thank you so much, Professor. We will take a little bit break for 3 or 4 minutes now, and others can have coffee a little bit, walk around and come back.